I titled this Better Together because when we're looking at the type of issues that we're talking about today, whether it's access or family-centered care, it's, I think, important for everybody to realize you don't do these alone. I mean, no, they're big, audacious issues, and it only is possible to make any progress if we have the masses working on it, that we have multiple organizations, we have people from across the spectrum of healthcare and non-healthcare working together to make a difference. So it's also a phrase that we talk about a lot in the hospital because we know that it takes many people to make light work. I always like to introduce myself a little bit so you know who's talking with you. I know many people, which is fabulous. This is a little bit like Old Home Week, and I've been able to meet some new people. But just a little bit about me. I love my four-legged friends of all sizes, and they are incredible. And I love to travel, whether it's in Utah, the West, or internationally, and I love to do it all with my beloved wife, Audrey. We manage to get away on a very frequent basis, and it makes such a difference to one's head. I am a nurse, and I am a nurse at heart. I am a nurse still in my, I don't practice at the bedside anymore, but I try and stay very knowledgeable about what's happening in nursing. And I have been doing it for a long time in a lot of different venues. I worked on a med-surg floor, I worked with oncology patients, I worked in the intensive care unit, and I've worked in nursing leadership. And I'm really proud Primary Children's got its magnet recognition, which is really about, thank you, about how nurses work with others, how nurses work with parents and physicians and others, as well as their professional practice and how they take research and evidence-based practice and put it to work. So it's a fabulous thing to celebrate. So that's me, so that's probably that's enough about me. I'm going to talk about both access and population health equity and social determinants of health and how some of that impacts our access, as well as family-centered care, and I'll switch partway through the presentation. But to start with population health, equity, social determinants of health, we know that where you live, work, play, age, makes a difference in your overall health. We know that in children, if they're in environments where they have repeated stressors, things that make their life more difficult, whether it's violence in the home or hunger or poverty, they will have a higher likelihood of cancer, of diabetes, of heart disease, and of course, mental well-being. We know that if you grow up in an area of lower economic viability, the chances are your likelihood to graduate high school are lower. And your age expectancy can be up to 10 years less on average because of the environment you grow up in. So we know this is a factor, but it doesn't mean that we just sit back. We can do things to make a difference, to identify families, children who are struggling, who might need help, who may not be asking for it or may not even know that they need it, and to be able to do things. So I'm going to talk about a couple of things, community coalitions, telehealth, and then food insecurities, because it's a particular issue that I think when we sit in rooms like this with an abundance of food, we forget that there are people who are having food insecurities. So the first thing I want to talk about is community coalitions. You're seeing this happening more and more across the country where organizations are brought together with diverse expertise and using the expertise of the many in order to identify a problem and then work on that problem. And we're doing this work in partnership with our Intermountain Community Health partners that are specifically working in the community area. And it doesn't need to be a hospital that is the anchor to this. You can have many different organizations do it, whether it's public or private. But the ones that I know the most about are from children's hospitals who have been doing work in the community. This is an example from Cincinnati Children's, and they started a number of years ago working with the community right immediately around their facility and brought together public, other nonprofits, health departments to work on some specific issues. And they've been underway, I think it's probably about 10 years or more now, and have seen some dramatic results where they've been able to actually decrease infant mortality, decrease patients coming to the hospital or admissions to the hospital. and look at increasing the language proficiency in schools. And that's not Cincinnati Children's doing, it's Cincinnati Children's working with these partners and being able to use their data and their QA skills to increase the overall abilities of that team. We decided that we wanted to do something similar here in Salt Lake and in Utah, and started to pull together a group of leaders, both at Primary Children's and throughout Intermountain, and started to say, so what would be our definition of health? If we were thinking about creating a healthy community and a healthy lifestyle, what are the areas that we define as being healthy? It's not just the health of your physical health, but what are the other things? And so this was the sort of first stab at what we thought was important. You can see chronic illness management, mental health, school readiness and education. So a number of different areas, not all of them being the expertise that Primary Children's or Intermountain is going to be bringing to the table. So the next step was really to bring together a coalition of providers throughout the community. So others that are really interested in this work, like United Way and the Health Department and Voices, and a lot of other members of our community who are also wanting to focus on the health of the community. And with that group, we were able to narrow down our 4 focus areas, being mental well-being, preventative services, safety and injury prevention, and lifestyle, and start to think about how do we take the next steps to creating pilot projects in these areas. And what we can bring as Primary Children's is data. And we have the ability to work with publicly available data. There's a database called Metopio, so we're able to bring all of the publicly available data together and be able to display it in a way that all of our partners can use it to measure their lagging success. So as we are working together on these common targets or these common goals, which is a really important part of doing collective impact work, is that as a group you identify what are the targets, what are the goals, what's the data that we need, what are the outcomes, and then you bring the teams together and you have those measures. So we're able to help by creating that common data, and then we can also help by bringing in some less available data. It's not publicly available, but data like number of times kids come to the emergency department. And we have that, we can blind it, it's not patient specific, but we can share that. So as we're doing things in the community to impact chronic illness or mental health, we're able to demonstrate whether that's having an impact and where kids are coming into the hospital. And then we're doing a couple of pilots, and we hope that through these pilots, we can make progress and make deeper progress than when we're working just globally. And I'm going to talk quickly about these projects. The first is with the Promised Neighborhood of South Salt Lake and Mill Creek, and we're working on mental health. We saw that they had higher rates of anxiety and depression, and we're working to do better screening in the schools and see if we can bring that down. The pilot with the Utah Pacific Islanders Coalition is around injury prevention or immunization. There is a much higher or much lower rate of immunization in the Pacific Islander community, and we need to understand why. How can we best work with that community in order to increase the immunization rates and understand why that exists? We've already had just a fabulous joint event, which was one of the pieces of advice that they gave us, and it's made a huge difference already. And then working with a pediatric trauma network and some rural schools, San Pete and San Juan County, Sevier County, around long gun and injury prevention because of the high rates of depression, low rates of access, and then the ability to, low rates of healthcare access and the ability to access firearms. And then finally, working with the Salt Lake County Parks and Recreation around activity. And they were able to do this wonderful pilot last summer to allow free access. And you can see a really nice uptick in activity hours that kids had last year. And I'm gonna just zip through the data slides here just to show that this is the sort of thing that we're sharing. This is well-being, and you can see in the orange and blue, that was the Mill Creek South Salt Lake, higher rates, the 12-month average rolling, and we can share this data and be able to track it. This is the as we looked at the immunization rates, very quickly popped out the disparity around the Pacific Islander community. And then this is the data demonstrating that we're seeing a nice increase in the summer of 2024 in activity level from those kids. And data is so important. It brings the team together. It allows us to make improvement. And over the next year, as we've brought these teams together, we're starting to see the impact that we can make. And hopefully next year, we'll be able to share even better data than we're able to share today. A couple of just comments generally about access. There are, and I'm sure you're going to hear this today, a lot of different things that impact access. Healthcare insurance. We know that not everybody has access to healthcare insurance. And there's this percentage of our population that will never, or likely for a very, very long time, will not have access. That discourages people to seek care, and they often end up being far, far sicker before they come in for care, and they have chronic conditions that are not well managed. So we know that insurance, poverty, the ability to get to your appointments, to buy all of the things that are not covered by insurance is a huge burden for our families, and we need to understand that better. And then just the increasing demand and need, particularly in the mental health arena. It is far outstripping the providers that we have, and we need to start thinking about different ways of providing care, different ways of using the team to be able to best meet the demands of the community. And then also get further upstream, and the more upstream we can get in the care that we're doing, the better off kids are going to be. So a couple of things that we're doing. One is I love this program. It's something that is just so fabulous that we're doing with our telehealth friends. It's school-based telehealth. And I'm sure you all know about school nurses and that we don't have enough school nurses, but the school nurses that we have are exceptional, and they are able to do things that keep kids in school. And if you can treat kids when they're in school and keep them healthy when they're in school, you decrease absenteeism. And you also are able to really overcome some of the equity imbalance of being able to access healthcare, because kids are in school. Most kids are in school, and if you look at chronic absenteeism from kids with chronic illnesses, there's higher chronic illness or chronic absenteeism in children of diverse backgrounds than you have in kids that are your typical Anglo child. So it's really a fabulous place to set up clinics, to do school care. And one of the programs we added last year was the ability for the school nurse, if they needed one extra level of care, they're able to go up to a certain level of expertise, but they need support in being able to provide provider-based care. Or they might need a test done that they don't have access to. So we were able to provide these really cool little kits, 19 labs, to the school system. We started with Wasatch School District, and they are able to do a number of things. There's a thermometer and a pulse oximeter and a stethoscope and a glucometer and a blood pressure reader and an otoscope and a dental camera to look in the mouth. And we can do a lot of point of care testing with the kit. And it connects into a provider through a platform called Connect Care. And then the child is able to stay in school. And absolutely the best thing. You can also bring the parent in. So we're able to call in and see whether the parent wants to join the call. And most of them, I would say actually most of them don't. They just let the provider work with the child, and because that's often their high school kids. And then we're able to keep kids in school. And I think that's what we want to do, is keep kids in school, keep them learning, and give them the very best access they can to that healthcare. We're really excited that we're able to expand this in this upcoming year to Canyons, Weber, Waterford, Iron, Washington, and Garfield school districts. And maybe Park City School District is going to opt in as well. And then we'll continue to look at how we can do that in larger and larger communities across the state, and just increase the access for kids while they're in school. And it doesn't stop there, because I think we have to think more and more about access to care. We know that every time you take a child away from their family, from their community, you increase the stress level of that child and that family. And the more care that we can provide to kids close to home to be able to keep them in their community, the healthier and happier they can be. Now, you cannot build a children's hospital in every single community. It doesn't work. We don't have enough of a population to do that. But there is a lot of care that can keep kids in their local community hospital or their local emergency department. And we have been working on that for the last number of years. We have this wonderful neonatal telehealth that the neonatologists are able to go into small nurseries across the state and be able to consult and keep kids in their nurseries so that their whole family can be around them. The family can be there to support the parents. We have subspecialty care for NICU. We used to transfer kids from hospitals all over the state into the newborn ICU at primary to do something like a neurology consult. It's a very specific specialty. There's only a couple of them in the entire state, and they would do that. And now we can do that remotely. And again, keep kids in their home community, which makes such a difference. Same thing with ED consults ED consults. This one's probably making the biggest difference on keeping kids in their home community. And we've seen that we're able to keep about 52% of the kids from being transferred. And that was the whole idea of the program. Let's be able to take experts, whether it's a neurosurgical expert or a trauma expert, take them to places across the community, have them be able to consult with the local emergency department, and determine whether you really need to send a kid all the way to primary children's. So to me, that's a really, it doesn't help primary children's, but it certainly helps the family, and it helps the local community, and it keeps them where they need to be for care. Okay, I'm going to switch gears and talk a little bit about social determinants of health screening. We have to know that there are people in need, and you can't look at people and determine whether or not they have a need. We have to be screening families. And I hope that all of you, as you've been going to your checkups, are seeing that you're being screened. I just went in for my annual physical, and before I got there, I got a pop-up on my phone, and they asked me all of the questions about my needs. As an employee, I got a survey asking about my needs. And I'm hoping that that is becoming more and more ubiquitous in our primary care situation. It certainly is in pediatrics. The Intermountain Medical Group does it like 98% of the time in all of the pediatric visits. So it's something that's really been embedded in the practice of the work that people are doing. So primary care is a fabulous place to do it because you're getting upstream. It's often when people are feeling comfortable, they're with a provider that they know that you can do screening. But it's not the only place we should be doing it. We're doing it in our emergency departments now. We should be finding it early. When you're coming in for one thing, we should be able to identify if there are other needs. And then we're starting to do it in our inpatient units. It started in the adult world because it was a Medicare requirement, but we thought, hey, let's do it in pediatrics as well. So we're doing it for the kids over 18, but we're also looking at patients that come out as high risk, and so doing it for our pediatric patients. And then this past year, we started doing it in our subspecialty clinics. We're up to about 65% of our subspecialty clinics we're doing screening. And then the most important thing is once you've screened, that you actually do something with the data. That's not us doing all of that. That is using our community resources and the fabulous partners that we have in our community, 211, and other great connections that we have to help meet the needs of our families. Not surprisingly, food has come up as the number one need for families as they come in. But we've also seen needs in medical care, dental care, transportation, housing, and utilities, and finding ways to help families, because we know if these needs are not all met, then the overall health of the child is not going to be good. You have to be thinking about it for the entire family and the entire child. I try and do this wherever I have the opportunity to talk about it, there is food insecurity in this country. And so if you are thinking about a place where you want to make a difference, I think it's a great place. I'm a big supporter of the food bank because I know that there are people who go hungry, and it's hard sometimes for us to imagine that. About 17 to 18% of the country has food insecurity. And about half of that, parents, these are families with kids in them, about half of that parents they protect the children, and they experience the food insecurity, but they protect their children. But if you're experiencing food insecurity, you're not going to be in your best place to take care of your kid. And we know that children need to have parents in their very best place if they're going to thrive. And then in another 8%, you have children who are occasionally experiencing food insecurity. And in about 1% of our country, kids are experiencing severe food deprivation. So I think it's important to remember this. So we are really fortunate. We have a food bank at Primary Children's, both at the Salt Lake campus and at the Miller campus. It is a community food bank. It's supported through our community health, and it is an amazing resource to anyone in the community. Families can come from anywhere if they need the food. And I think really important, we're able to give them a 5-day week supply of food for their family. And we carry some things that are unique needs for children who might be in a hospital. They might have special dietary needs. That was a really important piece when we started it, was to say what are the needs that may not be able to be served in a normal food bank because of food allergies or unique dietary needs because of diagnoses. But it was an important thing for us to start, but they also get connected to their local food bank. Sometimes folks just don't have the information of where to go and how to pick things up and that access piece, and so we're able to connect. So if you have folks, it's convenient at the Miller campus, it's convenient at the Primary Children's campus, it's a great way to start that connection, and it's very available. I always want to give a shout out to the Ronald McDonald House for what they do for our families and food security while they're with us and in the house. I have so many parents when I round talk about what a difference it makes to have a family room in the hospital, to be able to go and get a snack, to be able to nourish themselves, to participate with other families getting a meal that's being served by the community and share that common, that common sense of what it's like to be in a hospital. So my hat's off to everybody at the Ronald McDonald House and everyone who volunteers. If you haven't brought a team to volunteer at either the house or one of the Ronald McDonald rooms to serve a meal, I will tell you it is one of the best team bonding experiences you will ever have, because you get to not only bond with your team, but you get to have conversations with the families as they come through, and it grounds you very, very quickly. So if you're looking for a team building activity for your group, call Tony. She'll connect you. So, family-centered care. You're going to hear a lot of different, probably definitions of family-centered care today, different perspectives and comments on it. And I am so impressed by the speakers. I was looking through all of the different speakers that are here and the different perspectives and the expertise that you have to gain from in this room today. So you should feel just incredibly fortunate. But for me, family-centered care is about partnership between the professionals and between the family. And it is about doing that while we're providing healthcare services, trying to assure the very best health and wellness of the child and the family while they are in our care. And it honors both the families and the providers' culture, traditions, expertise that they bring to that relationship. And I think most importantly for all of those who are on that professional side, it really honors the expertise and knowledge that the family brings and makes a specific effort to elicit that knowledge and expertise of the family. That has to be not if you speak up, that's great. It has to be a really defined part of the program is that you're trying to get the family's input on everything that you are doing. I think anyone who works in healthcare knows it is a team sport. It is a team sport whether you are in a clinic, emergency department, in the hospital. You cannot do the work without all of the people around you. And that goes from the engineers to the housekeepers to the pharmacists to the physicians to the nurses to the respiratory therapists. There is this team of people that work. And one of the most important team members is the parent or the family member who is caring for that child. And we can never, ever forget that. So there are a few things that I think we can do to really help create this sense of team. It is not an individual support. It is a team that needs to be done. And the first is bedside handoff. And I know many of you have probably been in hospitals for a long time, and bedside handoff, the handoff between the nurses, took place in a room far away or in a hallway while the family and the patient were in their room. And who knows what was said, but it wasn't very transparent. And a number of years ago, we realized that that excludes one of the most important team members, which is that patient and family. And so we've moved to something called bedside handoff. Now, we do check with families to make sure they want us to do that, but we do bedside handoff in the rooms. And this allows us to include the family member in the conversation. And it's fabulous because you can say something and the parent can say, no, that's not what I heard. And they can correct it so that the myths that were often passed on from caregiver to caregiver are no longer happening. They get corrected very, very quickly. It also allows us to check all of the lines and the drips and everything that goes on. It makes such a difference in creating the trust level that is necessary in order to provide care from a long-term perspective. The other is family-centered rounds. Again, physicians and the nursing team used to round in a room or round outside the door, and the family was completely left out of it, and the idea was that you'd go in later and tell the family everything that was going on. Again, not part of the team. And family-centered rounds is based on that belief that parents have knowledge and expertise and things that they need to be bringing to the conversation. And it demonstrates respect and it creates trust if you do family-centered rounds. And very, very interestingly, we were part of a fabulous study that was done a number of years ago called IPASS, which is about family-centered rounds. And not only does it create that sense of trust, it is safer, better care. It actually reduced, this is pretty impressive, reduced serious injuries by 30%, or adverse injuries by 30%, and medical errors by 23%. And it didn't take longer. You know, there's this perception that if you do this, the families are going to interrupt and it's going to take a huge amount of time. It didn't take longer. It was better information, and we need to be practicing this way. This is the way that rounds should occur. And we did this as part of the study. We started getting back into bad habits, and we have re-energized family-centered rounds and are doing it with the expectation that we will move from service to service to service and make sure people are doing that. Everybody in rounds has a role, and I think that's important. The family has a role, the nurse has a role, the physician has a role, everybody has a role and a part to play. It's really important that this is really tailored and catered to every family. Some families want the rounds to happen outside the room because their child is sleeping or they're young, and we have to talk with them and really have that conversation prior to the rounds to make sure that we are meeting individual family needs. Some families actually choose not to be part of it. It's rare, but there is a family that might choose not to be part of it on a particular day. They want to sleep or they're not there. And so we need to make sure that the nurse is having that conversation with the family and making sure they get that opportunity. And there's one area that I think we have some experts in the room around behavioral health. I would say, unfortunately, at least for a lot of behavioral health, it's been the part that's the furthest behind in family-centered care. I mean, there are behavioral health centers that have people drop off their kid and they get to visit them a week later. And the centers have not been made very warm and welcoming to patients on an inpatient basis particularly. And when I look at our behavioral health center, it wasn't very family-centered and welcoming as either. And we have a fabulous leader there that as we were starting to build a new center said, we are going to make this a family-centered behavioral health center for kids. And Amanda Chowdhury's phenomenal, and she has been like beating that drum along the way. And one of the, I think, most brilliant things she did was she reached out to Ronald McDonald and said, can we put a Ronald McDonald room in our new behavioral health center? Can we make this sort of the epicenter of family-centered care for kids? So we'll be opening this new center in 2025. We'll have wonderful spaces for families and be very, very welcoming. It is built with that intent. And then both at the Miller campus, which just opened in February, and at this campus, the patient rooms will actually have accommodations for parents to spend the night on the inpatient unit. And we have not seen that before. It's pretty rare in the country that you will see that ability. Most likely, you probably switch the mom onto the long bed, the little kid on the short bed, but And teenagers probably don't want their parents staying, but we have children that are 6, 7, 8 years old, and if you can only imagine being in a mental health crisis and then having your parent leave you when you've probably never spent the night away from them, it is just added trauma. And if we can avoid that added trauma, we want to do that. One other area that we're doing some really nice work in family-centered care is with autism and some of the neurodivergent population. We're doing care plans where you actually call the family before you develop a care plan that's individualized for that child so that you really understand what is happening with the kid. And these testimonials are phenomenal. I've never seen a program work so quickly to change the experience that families have when the healthcare team knows what are their triggers and how we can better create a good environment for them. We have fabulous patient engagement or parent engagement at the hospital, family advisory committees. I realized when a wonderful Angela said this to me, the board is, we have all of these family advisory committees that help us, because it's not only when the kids are at the bedside, but help us provide better care to our families, guide us in what we need to do for care. But our families participate in all of these committees. We have a family member on the board, a parent on our board that helps us have that perspective of the family. And then all of these committees have parents on them. And I don't think this is enough. I'm hoping next time we can have 2 slides of where we have parents, because the perspective of the parents in those committees is absolutely essential to us doing our work. We also have parents who are on projects. If we're starting a project, we're starting to build, we're starting to redesign, you've got to get a parent on there. If you don't have a parent, you're not going to build it in the best way possible. We have parents that present. We have parents who are presenting to our residents. And if you think there's somebody who can tell you how to talk to parents better than a parent, I would challenge you. They are the ones that can give you that information on how best to describe what it's like to be a parent. And then they do it for our new hires. They do it in so many different arenas. And then one more shout out to the Ronald McDonald House. You can't do family-centered care without having your parents be able to be with the kids. And that's what the Ronald McDonald House Charities does for us, whether it's in the hospital or close to where we are. They are able to make sure that the families are getting the support that they need so that the hospital can provide the support that we can do to the patient. So thank you.